Thank you, Leandro, for this kind introduction. And my lecture is about the Doppler in peripheral artery disease. The learning objectives will be how to perform a Doppler examination in terms of the selection of the transducer and which protocol we will follow using B-mode, color, and spectral Doppler, and how to interpret a Doppler examination. How is the Doppler of the normal artery in cases of stenosis, occlusion, aneurysma, pseudo aneurysma, AV fistula, what we will see. A test to screen disease is the ankle brachial index. This is a test that compares the systolic blood pressure at the ankle, measuring the pressure of the anterior tibial arteries and posterior tibial artery, divided by the systolic blood pressure at the brachial artery, and the normal ratio is 1 to 1.3. It is abnormal when it is equal or less than 0.9, and we will see here how lowering the ratio, the disease becomes more important, from mild to moderate to severe PAD. Also, we may speak about a single segment disease, multiple segment disease, or tissue loss. If we want to map disease, we will use duplex examination of the arterial anatomy. Here we have the anatomy of the lower leg. We may divide it into 3 segments: the aortoiliac, comprising the lower aorta, the common iliac and external iliac arteries. Femoropopliteal is the common femoral artery, the beginning of the profunda, all the superficial femoral, the popliteal artery, and the crural level, the 3 arteries in the calf, the posterior and anterior tibial, and the peroneal artery, and also the dorsalis pedis. At the upper limb, we have the subclavian artery, axillary, brachial, and the 2 branches, the radial and ulnar arteries. How is the technique of examination? We will use a linear transducer of a high frequency from 3 to 12 megahertz. For deep arteries or a bigger subject, we will change to a curved transducer with a lower frequency. We have to optimize the grayscale and the color Doppler parameters and adjust the pulse repetition frequency to detect hemodynamic disturbance. We lastly perform pulse Doppler in areas of color aliasing. So the protocol will include the grayscale evaluation for plaques, color Doppler for narrowing and occlusion, and pulse Doppler for each arterial segment and at sites of plaque and flow disturbance. Here we have the beginning of the examination, the grayscale B-mode real-time imaging. The patient lies supine with the legs slightly rotated externally. We perform axial and sagittal scans. The normal artery has smooth, thin walls with a sonolucent lumen. In an abnormal artery, we will see plaques. We may see areas of stenosis and occlusion, and even extravascular disease. We turn then to core Doppler sonography that shows signals from moving blood. We may have an information on the flow direction and the areas of aliasing at the stenosis and color void at occlusion. Lastly, before the pulse Doppler, we have power Doppler sonography that is a variant of color flow Doppler. It is very useful for slow flow. It is less angle dependent. We don't see the areas of aliasing and less flow direction. The third step is to perform the spectral Doppler sonography. So we may place the sample volume at the center of the arterial lumen. Normally the width will be 2 millimeters, but we may expand it to encompass the whole lumen when we have small arteries. And we have to keep an insonation angle of 30 to 60 degrees. This is very important to have a good velocity. We sample at any area of plaque, lumen narrowing on color aliasing. How is the normal flow? The normal flow is a high resistance flow with the triphasic waveform. We have an antegrade sharp systolic peak, a reversed flow in early diastole, and antegrade flow in late diastole. The window will be clear because we speak about a laminar flow. Here we have an example of color and spectral Doppler in a normal femoral artery. The normal flow velocity at the arteries slows down from proximal to distal arteries. At the common femoral is normally between 80 to 100 centimeters per second and lowers to 60 to 80 at the popliteal artery and 40 to 60 at the tibial arteries. After exercise, the flow changes. It becomes from a triphasic flow to a monophasic flow. We have a rising in the peak systolic velocity and have an antegrade flow all over the diastole. Now I will speak about vascular regions and will divide them into occlusive and non-occlusive. Occlusive due to atherosclerosis, embolism, compression, or any inflammatory vasculopathy. Non-occlusive due to aneurysma, true and false, and AV malformation. Let's start by an occlusive lesion. The peripheral artery disease is as prevalent at least as coronary or cerebrovascular disease. It is present in about 10 million people in US yearly. It's more common in men than in women and may be based on arteriosclerotic plaques. And in this case, it will be gradual with a chronic course and makes time to develop collaterals. On the other side, we may have an embolism that it leads to a sudden acute event with acute ischemia. The presence of ischemia leads to the release of metabolites and progressive dilatation of arterioles within the distal vascular bed and the opening of small collateral branches, and these lead to diminished bed resistance. Now, how is the Doppler of an arterial stenosis? To grade the importance of the stenosis, we will have the ratio between the peak systolic velocity at the area of stenosis divided by the peak systolic velocity 2 to 4 centimeters proximally, that is the normal artery. A mild stenosis will be up to 19%. We have an increase in velocity lower than 30%. The waveform is triphasic, and we have a mild spectral broadening. With a moderate stenosis up to 49%, the velocity increases up to 99%, so the ratio will be lower than 2. The waveform is still normal, and we have more spectral broadening. With a significant stenosis between 50 to 99%, the ratio between the stenosis and the proximal artery will be equal or more than 2. This will be a 50 to 75% stenosis. When it is equal or more than 4, the stenosis is much important, between 75 to 99%. The other thing that we look for is the wave shape. We will have a monophasic waveform with a very important spectral broadening and post-stenotic turbulence. This is a case of a significant stenosis from 50 to 99%. At the stenosis, we will have high peak systolic velocity and a loss of the reversal flow. We have a flow all over the diastole with a marked spectral broadening, and below the stenosis, the peak systolic velocity is low, and is still monophasic with a spectral broadening, and we will have a tardus parvus waveform. This is a case of a partial thrombosis. We have a partially echogenic lumen with turbulence on color flow in the remaining lumen and a high peak systolic velocity. In case of arterial occlusion, at the place of the occlusion, we don't have any flow. Above the occlusion, we will have a high resistance flow with a low velocity, and below the occlusion, the flow will be low resistance with slow rise in amplitude, and here is a tardus parvus flow. So, to summarize, at the place of the obstruction, we don't have flow. If we see this low velocity, high resistance flow, look for a downstream obstruction. If we see this tardus parvus flow, look for an upstream obstruction. The accuracy for stenosis and occlusion is very high, is 85% at the femoral popliteal arteries for the detection of stenosis, and 96% for the detection of occlusion. But this test is time consuming because we have to determine the presence of peripheral artery disease in the whole leg. It takes about 20 minutes for each leg when applying color Doppler mapping. And that's why in some laboratories it's supplanted by MRA and CTA. Now, how we examine the bypass graft. The normal graft has a velocity and waveform similar to the native artery, so triphasic high resistance pattern flow. When we have a graft stenosis, we will have a monophasic flow with a high peak systolic velocity, and in this case we speak about less than 50% stenosis if the ratio between the stenotic and the pre-stenotic peak systolic velocity is less than 1.5. If it is more, up to 3.5 is more than 50%, more than 3.5 is more than 80%. I want to emphasize that a decreased peak systolic velocity less than 45 centimeters per second means an impending occlusion. Of course, we will have also a spectral broadening. Sometimes we may see perigraft collections, like in this case of a bypass graft infection with a large collection in the surrounding tissues. The stent stenosis has to be treated when it is very high, and normally it is treated by percutaneous transluminal angioplasty. Here we have the monophasic flow with a high peak systolic velocity before PTA. This is the angiography. And after PTA, we have a triphasic flow and the peak systolic velocity lowers. What happens in the upper limb arteries? The flow is very similar to the lower limb arteries. It's a triphasic flow. And I want to emphasize two cases or two situations of stenosis and occlusion. One is the thoracic outlet syndrome, that is a mechanical compression at the thoracic outlet. And the other is subclavian steal syndrome due to arteriosclerotic plaque at the origin of the subclavian artery, and will show a case of traumatic occlusion. Thoracic outlet syndrome is a compression of nerves and vessels at the costoclavicular space between the first rib and the clavicle. In most of the cases, we will see a cervical rib, and here the subclavian artery may be stenotic or even occluded. The stenosis is higher on hyperabduction. From a high peak systolic velocity, we will see a dampening with further abduction and an absent diastolic flow. In case of occlusion, we don't have flow and have a tardus parvus flow distally in the forearm. Subclavian steal syndrome is due to a stenosis or occlusion in the subclavian artery proximal to the vertebral artery origin. And so we will have in the vertebral artery a reversed flow in comparison to the normal flow on the other side, because the vertebral artery is supplying flow to the arm. This is a case of post-traumatic thrombosis of the ulnar artery with an abrupt cutoff of flow compared to the other side and a color void. Now, the examining of a dialysis fistula that may be of several kinds. This is a side-to-side, this is an interposition graft straight, and interposition graft in the size of loop. The normal flow in the fistula has a peak systolic velocity between 100 and 200 centimeters per second. The lumen is normal on B mode and color Doppler. When we have an stenosis, the lumen will be narrowed with a wall thickening. The peak systolic velocity will be 2 folds from the basic peak systolic velocity, or will be lowered less than 50 centimeters per second. Most of the stenosis occur at the efferent venous side. Now I will go to the non-obstructing lesions, starting by arterial aneurysma. It may be a bulge or focal enlargement of the vessel, reaching a diameter more than 20% of the original vessel. It will be more common in the popliteal and the distal superficial femoral artery. It has a preponderance in men. And be careful, because may be bilateral in up to 70% of cases and associated with abdominal aortic aneurysma in up to 40% of cases. So it demands the performance of a bilateral examination and also at the AAA examination. Normally it has a partial thrombosis. The ultrasound Doppler is superior to angiography for diagnosis and follow-up, and which are the indication for surgery or stent when we have distal embolization or the diameter is more than 2 folders. These are 2 cases of popliteal artery aneurysma that appears as a pulsatile mass in the popliteal fossa. This is a focal enlargement, and this is a diffuse enlargement. In both cases, we have a thrombus inside, leaving an opening lumen with a turbulent flow. And the other case that I want to present is the pseudo aneurysma. The pseudo aneurysma is a total disruption of the arterial wall with a pulsatile hematoma that is surrounded by the tissues and keeps communication with the artery. It appears as a pulsatile mass with a palpable thrill and audible to and fro murmur. It is more than 60% of all complications post-catheterization and appears up to 5.5% of interventional procedures. Again, the duplex ultrasound is the imaging modality of choice. What do we see? We will see an hematoma that has flow in the lumen. We speak about yin and yang flow, is bidirectional, swirling flow, antegrade in systole and retrograde in diastole with a turbulent pulsatile flow. And in the neck that is communicating with the native artery, we have a to and fro flow that is antegrade in systole and retrograde in diastole. This is a case of a pseudo aneurysma at the forearm, a patient coming after cutting with a glass. We see a large aneurysma with a bidirectional flow, and yin and yang flow in the lumen, and to and fro flow in the neck. Most of the pseudo aneurysma that are small becomes thrombotic spontaneously. If not, we have to treat it maybe by ultrasound guided compression, but in the last years is mostly treated by guided thrombin injection. And very large aneurysmas, pseudoaneurysmas need a surgical closure. This is a case that we make a treatment of the pseudoaneurysma, injecting through a small 22 gauge needle inserted into the pseudoaneurysma, 0.5 to 1 milliliter of 1,000 unit per milliliter bovine thrombin under real-time ultrasound guidance. And we may start seeing the thrombosis without minutes, without seconds, and with a success of 93 to 100%, we see a totally thrombosed pseudoaneurysma, and the flow in the femoral artery we have to look for. Be aware of the pseudoaneurysma with a wide neck, because may have a risk of flowing the thrombin to the native arteries. And this may lead to complications. The other non-obstructive lesion is the arteriovenous fistula. Some of them are congenital, but most of them are acquired, maybe traumatic or iatrogenic, maybe single, multiple, or combined with a pseudoaneurysma, and sometimes have effect on the cardiovascular system. This is a case of an AV fistula between femoral artery and femoral vein. We have a false vascular channel with a mosaic pattern due to very high turbulent velocities flowing in the fistula. At the level of the fistula, we have this high velocity turbulent flow. At the level of the artery, there is a high velocity flow monophasic, because it flows directly into the vein. And at the level of the vein, the flow will be pulsatile. So we speak about arterialization of the vein. We also may see this, this color in the surrounding tissue due to turbulent continuous flow. We speak about color brute. This is a case of a subclavian AV fistula that was caused after repeated punctures for central venous catheter insertion. We see the communication between vein and artery. Here in another scan, we see better the fistula. And here we may see the very turbulent flow in the fistula and the color brute surrounding it. This is a brachial AV fistula. A patient that came with a warm arm swelling after trauma. We see the high velocity turbulent flow at the level of the fistula, the low resistant arterial inflow, and the high velocity pulsatile venous efferent flow. This is a case of an arterial dissection that was lead to insertion of the guide during catheterization. We see this narrow canal parallel to the artery with a turbulent flow. In conclusion, duplex sonography is an excellent triage method for symptomatic patients. It allows the diagnosis and follow-up of aneurysma, pseudoaneurysma, AV fistula, and monitor percutaneous interventions, bypass grafts, and hemodialysis fistula. I thank you for your attention.
Fantastic. Thank you so much, Diana, because you summarized in an amazing way something that it has a big extension. It's very long topic and sometimes very difficult topic to present and to deal with. And you made it simple and again, an extraordinary summary. Congratulations, and thank you so much for being here today.